Hello, good morning, everyone.
Good morning, Dr.
Okay,
Bugs.
yes,
We here, Dr. Hayashida here, as many
yes,
distinguished
yeah,
panel
okay.
cheers. Okay,
Okay,
you wanna start?
so on the Saturday first live session, we're gonna start. And first of all, I'm gonna introduce the very nice team and Dr. Kang and the first assistant and Dr. Go and Dr. Kim and the echo specialist standby. And this procedure also we're gonna support the intracardiac echocardiography ICE assist the TAVR procedure. Okay, we're gonna start the patient presentation. Dr. Kang, can you review the patient background?
Yes, thank you. The patient is 85-year-old female patient, very old patient with admission for dyspnea. She had only history of hypertension, and we evaluated echocardiography, and it showed severe degenerative aortic stenosis. And also we checked the angiography, and she has some stenosis on LAD and RCA, so we previously performed the PCI for the LAD and RCA. Next slide, please. And her STS mortality score was 3.389%, a low-risk patient with old age. Next. And her echocardiography showed LV ejection fraction of 49% with aortic valve area calculated is 0.36 centimeter. Very tight aortic stenosis. And peak and mean pressure gradient was 94 to 61 millimeter mercury with transaortic max velocity of 4.9. And other EKG and CT showed no significant abnormalities. Next. And she also experienced acute kidney injury just after the checking the CTs. Next. And she shows the normal sinus rhythm. Next. And the chest X-ray shows cardiomegaly. Next. And this is our routine CT evaluation protocol. We check the short and long diameter of 20 and 25.7, and the annulus area was 418, and the perimeter was 73. Next. And the sinus valsalva size was 661. That means that sinus to annulus area ratio is 1.58, a little bit small. And ST junction size was 578, and ST junction to annulus area ratio was 1.38. Next. And this is the LVOT, LV outflow tract morphology. That means the size is sufficient, and you can see a small calcification. Next. And this is the total amount of calcification of the valve, and total amount is 419, a little bit higher compared with the average. Next. And calcification, you can see a small calcification nodule is going under the annulus. Next. And coronary height is sufficiently high, more than 12. Next. And this is iliofemoral arteries. You can see there's no severe disease, no plaque. Next. So this is a sizing chart for
Yes.
SAPIEN 3.
So based on the CT algorithm, and we select 26 SAPIEN 3, and we're gonna initially do 2 cc on the field. That means just a 15% oversizing. Looking at the hemodynamic graph, and definitely 이거 한번 밑에 노선생 보여주고 있지? 저기서
Can
보고
you
있나?
please show the
pressure gradient?
hemodynamics?
Okay. So, and this is LV and ascending aorta simultaneous hemodynamic. You can find how much significant the pressure gradient. Also, we check the echocardiography using transthoracic and the ICE. And okay, Professor Kim, can you present
This is
echocardiography?
Kim from Asan Medical Center. Can you show the echo image right now? This is a parasternal long axis view acquired from transthoracic echo. Now the LV function looks normal. You can see a heavily calcified and severely stenotic aortic valve. Next. This is a magnified view. Next. On color flowmetry, the flow acceleration during systole and trivial aortic regurgitation during diastole. Next. the cuspid morphology is tricuspid. Next. Every function looks normal and no regional wall motion abnormality right now. Next. The mild degree of functional MR was noted. Next. Next. In CW tracing, the peak velocity are around 5 meters per second. Thank you.
Okay, we also checked the IC image.
yeah,
Could you show save the IC image?
Intracardiac echo catheter is on demand today. We are using different one than yesterday. We show some images previously acquired just before the procedure.
Okay.
Okay.
처음부터. Okay.
Yeah, this is a short axis image of LT valve. This is a beautiful image of good resolution. You can see heavily calcified three cusps right now, the upper side of the valve.
Okay.
Yeah. Next.
Good. Yeah.
Next. Okay.
This is a long axis image of left ventricle. You can see mitral valve left side and septal wall and posterior wall. There is no effusion right now. Yeah. Next. 혹시 LT valve long axis 이미지 좀 보여줄 수 있나요? 아까 보면. There is some technical issue. We'll show beautiful image after the procedure. Yeah.
Okay, got it. So if I'm gonna summarize this patient, this is in daily practice frequently encountered patient, 85, relatively low risk patient, and the creatinine was after CT scanning, creatinine goes up to 1.8. So today we plan the usual practice. We use the MAC and without general anesthesia, as well as we will do TAVR procedure, just the minimal contrast TAVR procedure and with IC support. So and the old age patient is vulnerable to contrast nephropathy. I'm gonna hear about what is your in-house strategy to reduce to prevent contrast-induced nephropathy. Is Kentaro what is your strategy usually?
Okay, thank you very much for the question. It's a very nice case, and I think it's very important to reduce the amount of the contrast. And our practice is to dilute the contrast to 50%. And as far as we are familiar with the procedure, we can also reduce use the diluted contrast, and we can also do zero contrast TAVR procedure, putting the catheter in the right coronary cusp and the non-coronary cusp and left coronary cusp.
So and some physician is the second case MK Hong, and they use the zero contrast TAVR procedure and based on the TE image. Have you experienced the TEE guided positioning and no contrast, zero contrast the TAVR procedure?
So actually, the Evolute R or Pro will be nice for the echo guidance, the positioning. But the for Sapien 3, it's a little bit difficult. So I usually use the positioning with wire if we cannot use any contrast. So what is your practice in Asan Medical Center?
So and the high creatinine patient, sometimes we experience zero contrast. The the TAVR procedure. If you're gonna use Evolute R, zero contrast T guided is possible, and sometimes pre-planning we did MRI and the transesophageal echo instead of cardiac CT scan, but the problem is MRI image is too much coarse and not clear.
Yes, that's
Resolution was limited, as well as even though we're gonna use a 3D transesophageal echo, the exact sizing is it's really it's problematic. So, and so our strategy during the procedure, we try to do just a little bit contrast less than 10 cc the overall procedure. So for this case, I didn't any drop the contrast until now.
So sorry, Dr. Park, is the patient under GA, general anesthesia, or LA?
This is MAC and without the general anesthesia. The
Okay.
monitored anesthetic case.
So why don't you use TEE, esophageal echo? Because we find that the image by TEE is much more stable and usually much more clear when you position the valve and all this.
Yeah, so I think the balloon, the self-expandable valve is TEE is very useful to guide the positioning, but the balloon expandable, just a little, very short time we should position is that during the procedure, I think the TEE is not much helpful to guide the exact positioning. Okay, we're gonna push up.
Meaning is for the protection of renal functions, minimize contrast, that is main purpose. And to be honest, SS3 balloon expandable TAVR procedures, we believe that the procedure is angio-guided procedures. We evaluated supportive, any imagings as we can help. We can have some information. So, all right, so you're going to see that, what's happened.
This is 26.
Not too much contrast.
Yes, it's, until now
we can clearly see that the horizontal line by presence of calcium, something like.
Okay, and pull back and push up. 자, 조금 더. Okay, the 26 2 cc on the field, and then we're gonna make a curve. This is a MAC. The viral is okay. 자, CT measure the planar view. 여기 CT measure planar view죠. 자, 뷰 맞지?
We also could save the contrast because we already checked the optimal fluoroscopy angle with CT.
Okay, this is 이렇게 놓고. Okay, patient pressure is okay. 자, 잠깐만 내가 볼게. 천천히 볼게. 우리가 여기서 잠깐 조금 쓰면 얼마 쓰게 돼?
5에서 7cc. 네.
오케이, 테스트. 3cc, 3cc. 오케이, got it. 자, 조금만 더 들어갈게. 오케이, 이 정도. 오케이, got it. 잠깐만 피부텔 빼고. 자, 테스트, 리를 3cc. 오케이, got it. 자, 준비됐지? 그 할 때는 한 5cc에서 10cc 쓰면 돼.
Let's be ready.
자, pacing on. Contrast. 오케이, 고. 쭉. 1, 2, 3, 4, 5. Deplete.
Deflate.
Okay, pacing off.
Just one shot of a contrast injection.
Right.
How much do you
just use 5cc? Frankly speaking, 7cc.
7.
Just a little 7cc. And then we're gonna check the ice image.
Yeah.
Okay. 요거를 조금 뺄게. Just use 7cc.
Yeah, with experienced hands, just one shot is sufficient.
자, ice image 좀 보여주세요.
just positioning,
Yeah.
and then you want to follow up with
떼고.
ICE or transthoracic echo.
Because the team is so
left
experienced.
ventricle long access image. There is no effusion right now. Every function looks good.
There is no effusion and every function is good.
In fact, in our lab, actually the CT algorithms, the pre-evaluation, the meticulous evaluation, the size-wise fine-tuning, that is more important.
자,
So we're going to
빼버릴까요?
choose the 26 and 2cc on the fill. Area of stretching
인데스는
is
편하게 내
15%.
페이싱을 빼드릴게요.
We have some confidence, right?
괜찮아요.
And so 400 amount of calcium, and
좀 뺀다.
etc. The 25 will be okay.
불편하면
And so we're going to say
페이싱
that
빼드리.
just deploy.
Almost there.
Great.
So and the eyes some different device. Yesterday we use Abbott AccuRex.
Yes, this is the Abbott, and yesterday we used
this is a much thicker view flex.
Yes.
Steeper than yesterday one.
Yeah, each one has pros and cons, and okay, good.
This is the shoulder axis image almost there.
Good position. All right.
Well, good. So actually, the echo is not used for positioning or monitoring. It's just used preoperatively and postoperatively to assess the result and any complication, pericardial
Yeah,
effusion,
definitely.
etc.
Okay,
I
okay.
mean, it's very good demonstration.
레스피레이션에 따라서 조금
Can you
달라지는구나.
see the LT valve right now?
Okay.
Very difficult still. So we are. Professor Kim is really had us.
Yeah,
much
right here.
effort.
Please turn on the color flow.
All right.
Color flow.
Doppler, please.
Okay. L2 valve. Okay. Okay. 조금 확대해서 거기를.
I think trivial parabolic right over there.
Depending on
So
your
please take your
decision,
time.
I'm
Yeah, I
gonna
know.
finish. Procedure is already done. Remaining time is imaging time.
Yeah, thank you very much.
We have plenty of time.
Yeah.
And we can see the very nice short axis
Yeah,
view.
yeah.
Not much, right? PBL. Maybe 12 to 1 o'clock. There's some
PBL.
PBL.
Yeah.
Uh-uh.
Less than mild, I
Slightly.
think.
Less than mild.
Less than mild.
Okay.
less than mile. So, Duk-Woo, you have to have considerations of lead dilation with the 1/6 more, 2/6 more. What would you do that?
Yeah,
Just to finish the procedure.
I think. Okay. This
This
view
is a long
okay.
axis.
Okay, good.
In the middle of long
yeah,
axis
great,
and short
great.
axis. Yeah.
조금 더 와이드하게. 이걸 그렇지. 칼라 3대.
Great picture.
Yeah. Thank you.
Oh, there is just
In the middle of a long axis, short
Yeah.
axis, and
Okay,
the
good.
transition zone. Yeah.
just a little PVL.
Could
Yeah,
you explain the image?
Yeah, but this is a
Okay.
short X in the middle of a long axis and the short X image and combined with. But I think it's better for the evaluation of PVL rate. 컬러 좀 켜주세요.
칼라 좀. 오케이. 거기 잘 보인다. 오케이, great.
Great image.
What about the PBL?
Trivial.
PVL. Okay.
Would you like to check AR index also?
Okay, got it.
Because
Okay,
it
got
also
it.
not
Okay.
consume any contrast.
Definitely. 우리 AR 인덱스도 한번 재봅시다. Okay, we're gonna check up the AR index. 자, 보면서 LV 빼고. 자, 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3, 3. Okay. Our routine
results is very
usually,
nice.
Yeah,
I'm just wondering
usually
whether
check the AR
would
index
anyone
as well.
consider also putting a 23 valve with 1 cc extra. I was just thinking whether sometimes do we have to
AR
consider
index
also
바로
the
계산해서 한번
LVOT
보시죠.
size in terms of the size, whether if you put in a larger valve, would there have any implications also of the conduction aspect as well?
I think that's a very good point.
Okay.
And in case of the borderline cases, we also need to take into account
땡기면 안 돼?
the calcification of the leaflet as well as the LVOT calcification, whether to choose the bigger one with endofilling or a smaller one with overfilling.
Okay, press. And then
Must say it's perfect.
we will check the air index. Okay, good. 이쪽도 에어 빼고. Okay.
Can you please show the pressure curve?
저 프레시 커브를 우리 그 오디언스들이 볼 수 있게 바꿔 체인지 해주세요. Could you measure the AR index? Okay, I think it looks more than
It seems good.
more than 3.0. It just means trivial.
Yeah. Yep.
얼마 나와요? AR index?
And
You're gonna on site.
Cadero, do you usually measure the AR index
Yeah,
in
yeah,
your lab?
yeah. We are
No,
usually measure.
lab, yeah, we're also
다 됐어요?
measuring the simultaneous measurement.
Okay, 이거
but
exchange하고.
we don't calculate that much.
요거 됐고, 요거 이제 바꿀게. So and we're gonna finish all Okay.
So would you explain the AR index, Duk-Woo?
Yes, we usually measure.
So we don't have any aortogram here.
Yeah, right. It's after checking the AR index and approximately is 10 is very severe. The less than 10 is very severe. 10 to 20 is moderate. More than 20, 30, more than 30 is just trivial, and 20, 30 is just mild AR.
What about this patient?
Yeah, this patient 25,
25?
26, just mild AR.
25.
Yeah.
All right, still hemodynamically,
Yes.
I see
Yes.
there are some demonstrated
우리 에코도 볼 필요 있나?
PVR small.
So, and the audience wants some little contrast. Depending on you.
Can I have a comment?
Okay.
I believe it's all right. I think it's okay. It's a creatinine 1.5.
Yeah.
Five.
원샷만 한번 찍어볼까?
This is James.
바꿔. Okay. Jiang.
Dr. Park.
Yes. You contrast.
I just have a general comment. So the great demonstration, excellent. I think it will be excellent result. So my general question is, your ISIS cost about $2,000, and you save 10 cc contrast. So I just wonder for general comments, you use your local anesthesia, and you try and save the money or make patients more comfortable. I would say, as an angiogram at the end is really helpful to determine whether positioning or whether need a river. I think one angiogram probably solves all the problems. So I would say won't save 10 cc contrast at the end, and rather use ISIS to determine the positioning.
All right.
So,
I totally agree. However, in terms of this is a new technique, technology for the imaging. So we're gonna find how to use usefully and efficacy for the TAVR procedures, and the cost-effectiveness concern is later. So we have to consider that one. However, at first stages, we're gonna find it's brand new, technique. How could it be helpful for the TAVR procedures in some cases, zero contrast in some cases.
Yes.
So we're gonna find it.
Okay,
So
we're gonna show us the.
no, I think it's a very nice imaging. But
You're gonna show us the final imaging.
I know there's a two extreme zero contrast with minimum contrast.
Sure, please.
How much different?
Okay, the
5
audience.
cc?
Yeah, just
No.
5 cc. Okay, ready? 자, shoot. Okay. Everybody
I think it's great.
satisfactory
It's
the
perfect.
result. Just I think the minimal and the mild AR we totally how much use 10 cc.
10
Right.
cc.
Okay, 10 cc.
Yeah, 10 cc
I think
Sure?
Yeah, we are sure. It's
10
frankly
cc in
speaking,
total.
10 cc total. Yeah.
10 cc injections saved $2,000.
Cost-effective analysis, Jian is right. So I think the overall procedure
You
is
only
very.
use the 70 cc. That's a great.
Yeah.
I was curious that how to check your vascular access result. When you finish the you don't want to inject a contrast.
Yeah,
and how you routine
sometimes you inject
check your
contrast and
vascular access.
we also check sometimes ultrasound.
Yes.
Yes, we sometimes checking the ultrasound
Yes, that's
patents,
right,
and we're gonna use the ultrasound this patient.
Yes.
Okay. Yes.
Great cases.
Thank you. And
All
this
right.
is very straightforward, and
All right, thank
we
you.
try to show the minimal contrast TAVR, and the result is successful. Thank you.
Okay,
So
great.
great case. Congratulations.
Thank you. Thank you.